So there's more people connecting. I'm just admitting each one of them. We can give some 2 or 3 more minutes to admit all the participants. Okay, thank you. Welcome, Dr. Malena. We are about to start. We have already Dr. Kiria,
Hi,
Dr.
Narvin.
Bernarda. Hi.
Hi, Kiriaki.
Hi there, nice to meet you.
Thank you. Nice to.
Okay. Good morning, good afternoon, or good evening to everyone. Thank you for joining us today. It is my pleasure to welcome all of you to this webinar. I am Dr. Norvel Mera Chu, which is the current ICOH National Secretary of Peru, and I am glad to be part of the organizing team because this activity is a joint effort between the Scientific Committee of ICOH on Shiftwork and Working Time, the Working Time Society, along with the National Secretary of Peru. I know that we have participants from Latin America and other participants from other regions. So today we will have a speaker in English and one speaker in Spanish. The webinar title is Shift Work and Workers' Health from Research to Prevention. I would like to start sharing with you some slides about what we can find here in Peru and other Latin America countries. For example, in agriculture, as you can see in these pictures, we have some farmer workers from grapefruit companies that dedicate to cut branches. But in the same company, we have also workers that dedicate to use agrochemical products to, improve the growth of the grapefruits or to avoid the pests that can affect the grapefruit. But we also have workers from maintenance area, and the common thing from these groups of workers in the same company is that they have to be there from 6 a.m. to 4 p.m., which implies to be awake from 4 or 4:30 a.m. 4:30 a.m. until 4 p.m. So it changed a lot, not only their job schedule, but also the time that they have to rest and to be, sleeping to recover from the next day. So when I was working in the risk exposure of these workers, there are some questions that I ask to myself, like at what time they really sleep, how long the work day is really working for them, and at what time they go to bed. Another example is the construction sector here in Latin America, because most of the projects are not in the city, are out of the city, for example, in the highlands of Peru or other countries, and they have to travel 2 hours until the project, so they prefer to spend from 10 to 14 days working, and then they took a break, 3 or 4 days for a break out of the project so they can go back home. But of course, it implies some changes in their schedules, and they also do very high risk activities, as you can see in the pictures. So is there only a work environment that can affect their health, or there are other factors, for example, the area or the house they live during those 14 days of work that can affect their sleep, but also their global health status? And at what time do they really go to sleep? So this is why we consider very important this March, this month, as the World Sleep Day, as the World Sleep Month, to commemorate the importance of not only a good quality of sleep, but also the importance of the sleep on our health. And it is my pleasure to be part of the team who organized this webinar with the Scientific Committee of Shiftwork and Working Time. Because in 2017, I attended to my first symposium organized by the Working Time Society, and I know how they really work hard for increase the awareness about the shift work and working time, not only for working population, but also to general population. So I would like to introduce you to Dr. Imelda Wong, who is the chair of this scientific committee. Dr. Imelda Wong is a PhD and the coordinator of the ICOH Center for Work and Fatigue Research and a subject matter expert on occupational fatigue. She is also the chair for the International Commission on Occupational Health Scientific Committee for Shift Work and Working Time. She has over 15 years of research experience studying risk associated with non-standard schedules such as long work hours and identifying effective mitigation strategies. For part of her PhD dissertation, she conducted a longitudinal study of the association of cardiovascular disease and hypertension among paramedics using 50 years of daily work history data linked to death certificates, hospitalization information, and physician visitation records. More recently, Dr. Imelda has been a guest editor for two of them journal issues, Industrial Health and the American Journal of Industrial Medicine, which highlighted the determinants and risk of work-related fatigue and effective mitigation strategies to advance worker safety, health, and well-being. The articles in these issues identify knowledge gaps and needs and suggest future directions for occupational fatigue research. So welcome, Dr. Imelda. Please, could you give us some words to the attendees?
Yes, thank you very much for that introduction, Dr. Chu. I just wanted to have a small correction. I just completed my tenure at the National Institute for Occupational Safety and Health, but I do remain committed to the topic of occupational safety and health as my role as the chair of the ICOH scientific committee on shift work and working time. And so with that, it is a pleasure to join my esteemed colleagues today to provide a session on shift work and health. I first met Dr. Chu at the Working Time Symposium in Coeur d'Alene in 2019, and I'm really thrilled that we can continue to work together to promote worker safety and health, particularly amongst those who work non-standard hours. It's been estimated that approximately 30% of workers in industrial nations are employed in non-standard schedules, such as shift work. However, the numbers may be even higher amongst those that are working in developing or emerging countries. In addition, these numbers may be continuing to grow as our work changes with globalization, requiring working across time zones, advances in information communications technologies, and growing demands for goods and services. And so without going into too much detail and taking away from our presentations, I think it's safe to say that there have been a number of adverse health and safety concerns associated with shift work, and we don't mean just night work. And so you heard Dr. Chu say there are things like early morning starts, long work hours, including long commutes, all irregular scheduling. All of these can interfere with sleep and circadian rhythms. And so this can have short-term effects such as reduced concentration and memory, and over the long term can be associated with chronic disease such as cancer. So I'm looking forward to today's presentations that will address what we can do to mitigate the occupational safety and health risks associated with shift work. And as Dr. Chu mentioned, what makes today's webinar so unique is that it will be offered in two languages, both in English and in Spanish. And I'm hoping this means that we can reach a wider audience. So thank you to all of you who are joining us for today. And I hope that you've come with lots of questions for our esteemed speakers and we can get a really good discussion going. And with that, I'll turn things over to you, Dr. Chu. Thank you.
Thank you, Dr. Imelda. It's really great to have you here with us. And for starting the webinar, it's my pleasure to introduce you to Dr. Kyriaki Papantonio. Dr. Kyriaki is a medical doctor and epidemiologist. She is currently Associate Professor in the Department of Epidemiology in the Medical University of Vienna, Austria, and an Associated Researcher at the Global Institute of Global Health in Barcelona, Spain. She is an expert in circadian and sleep health with over 10 years of international research experience in studying the association of night shift work with cancer risk and key biological mechanisms such as circadian and sleep disruption underlying the carcinogenicity of night and shift work. She is currently the local PI and Shift2 Health and EU-funded project on developing strategies and interventions for preventing obesity in night shift workers. She is a board member of the Working Time Society and the secretary of the ICOH Scientific Committee on Shift Work and Working Time. Welcome, Dr. Kyriaki. I'm going to stop sharing the presentation so you can be the host. And I will make you the host. Welcome, Dr. Kyriaki.
Hi, just a second. I'm trying to share my screen. Just give me a sign if you can see my screen in full screen mode.
It is uploading. Yeah. Now we can see the presentation.
Excellent. Thank you so much. So hello, everybody. Buenos tardes. Good evening from Vienna. It's 6 p.m. Central European time over here. So it's a pleasure to be here today. And I would like to start by thanking Dr. Norville Merachu for the kind introduction, the invitation, and the great initiative of a webinar dedicated to shift workers' sleep health. So my talk will be in English, but I'm very happy to take questions in Spanish and hold the discussion in Spanish. So my Spanish is not as good, but is good enough to defend myself in a discussion. So in the next 25 minutes, I will try to summarize some of the work I have done together with a lot of great collaborators over the years on the interplay between night shift work, sleep disturbances, and cancer risk in 2 studies. And in the second part of my talk, I will touch upon biological mechanisms that underlie this carcinogenicity or pathogenicity of night shift work, and I will talk about shift work adaptation. I will close my talk talking about some ongoing work we're doing within the Shift to Health project, which is an EU-funded project on prevention of obesity in shift workers. So night shift work is a very common occupational exposure. It's estimated that 10 to 20% of the working force is affected by night shift work in the EU and the US, and it's an integral part of our 24/7 society. So night shift work is more common in men than in women, and it's widespread across a wide variety of occupational sectors. Some were mentioned earlier today, including the health sector, but not only, also communication, transportation, hospitality, and several industries. We also need to note that night shift work is not a simple, but rather a complex exposure with a large variety of round-the-clock work schedules that differ by type, shift work intensity, speed and direction of the rotation, length of shifts, number of consecutive shifts. Therefore, the study of night shift work is not always straightforward, and it's not a black and white exposure. So we also know that occupational safety and health risks that arise from night work may vary with the characteristics of shift work schedule. And this is important for recommendations and policies for shift scheduling, for example. So in addition, night shift work leads to exposure to artificial light at night, changes in the sleep-wake cycle, circadian misalignment, and mistimed exposure to diet and activity patterns. And each of these factors has further biological consequences that will be discussed later. In particular, with regards to sleep, which is the focus of today's webinar. So night workers have to stay awake during normal sleep hours. They often obtain fewer sleep hours because they have to sleep during the day. And they can also experience sleep of worse sleep quality. This has been demonstrated in a variety of studies, both in the lab and in the real world. And it's likely that the metrics that I mentioned previously of night shift work, such as the intensity of night shift work, contribute to different degrees of these physiological changes or effects, including the impacts on sleep. So over longer periods, these changes may have profound influence on physiology, safety, and long-term health outcomes. Night shift work has been associated with over 100 health outcomes, including acute effects, so jet lag-like effects like sleep problems and gastrointestinal diseases. And in the long run, it has been associated with a number of chronic diseases, including cardiovascular disease, type 2 diabetes, obesity, metabolic syndrome, and cancer. In relation to the carcinogenicity of night shift work has been classified as a probable carcinogen for humans by the IARC of the WHO in 2008 for the first time, and again in 2019, based on sufficient evidence from animal studies and limited evidence from epidemiological studies produced in the last 25 years. So the main reason for not upgrading the classification to class 1 was that bias, chance, and confounding could not be entirely ruled out in epidemiological studies. So in sum, epidemiologic evidence in humans remains limited, and there is a need for better quality studies, as well as more human mechanistic studies. Several questions remain open after the second IARC classification, and one of them relates to individual susceptibility. So it has been hypothesized that certain individual and behavioral characteristics of night shift workers, such as, for example, chronotype or diurnal preference, clock gene variants, and sleep characteristics may affect tolerance to night shift work, and that this could impact cancer risk differently. So our group is doing work on several of these areas, but for today I will focus on research we have done in conjunction to sleep. So as discussed earlier, sleep problems are very common and often normalized among night shift workers. It is estimated that at least 1 out of 4 shift workers may develop shift work sleep disorder, which involves clinically significant insomnia symptoms. So chronic problems of sleep problems, short sleep, and also impaired daytime functioning. So sleep disturbances among night workers lead to increased risk of fatigue and workplace injuries, and so they are of great importance for occupational safety. Whether these workers are also at an increased risk of chronic diseases, I would say is rather still unknown. And this is one of the research questions that we have tried to answer. So we hypothesized that maladaptation to night shift work indicated by the existence and report of either short sleep or long sleep as a compensation of the chronic sleep loss, as well as sleep problems, may further increase cancer risk in night shift workers. And in addition, a few more words about shift work adaptation and adaptability. So we know that there are important inter-individual differences in diurnal rhythms, including melatonin and chronotype, and that these differences may influence the ability of individuals to adapt to night shift work. So can we measure circadian adaptation, and how is one of the questions that remains. Then we know that full adaptation to rotating night shift work is generally very difficult. Even in permanent night shift workers, we don't find evidence of full circadian adaptation. And so the question remains, is adaptation good for long-term health, and how much of adaptation is safe? And last, we know from many decades of research that individual factors such as age, chronotype, and genetic susceptibility may influence the adaptability to night shift work. So previous research has established a link between circadian adaptation and sleep and light. So these are optimally timed light is considered chronobiotic, but how much shift schedules and behavioral factors matter? So these are some of the questions that I will try to answer. So coming back to the previous question regarding maladaptation of night shift work and whether this influences cancer risk in night shift workers, we used data from a cancer case control study that was conducted in Spain. This study was recruited cancer cases and controls from 2009 to 2014. Specifically, cancer cases were patients with breast, prostate, colorectal, gastric, or chronic lymphocytic leukemia, and population controls. A total of 10,000 subjects were recruited. And face-to-face interviews were conducted, and follow-up telephone interviews were conducted. And within this study, we previously had conducted analysis on the association between night shift work and cancer. So this is old analyses that are already published several years ago, where we were finding that night workers have a higher odds of different types of cancer in the range of 10 to 20% for ever night shift work exposure, which was higher for long durations of night shift work compared to day workers. Compared to participants that had never experienced night shift work. In addition to that, when we analyze sleep duration among night workers only, we find further increases in the risk among night workers that report short sleep or long sleep. And this risk pattern was consistent for different tumors, in this case for colorectal and gastric cancer. So these results suggest that night workers with extreme sleep durations may be more susceptible to the negative effects of night work, or that participants with night shift work that develop or have extreme sleep durations or sleep problems have a higher risk for gastrointestinal tumors compared to night workers with a healthy sleep, with a more healthy sleep. However, I must note that in this study, sleep problems could not be attributed to the night shift work. and also that reverse causation can partly explain some of the increased odds ratios here, because due to the study design, it was a case control study, sleep was assessed near recruitment of the participants, which means, which may also mean near cancer diagnosis for cancer patients. However, the findings of a potential joint effect of night work and sleep disruption, although it was novel for these specific endpoints, it corroborates previous evidence on other endpoints such as cardiometabolic disease risk. So next, later on, we tried to confirm this hypothesis in a prospective cohort study. And here we evaluated the independent and joint association of rotating night shift work, sleep characteristics, and thyroid cancer in ICOH. Why thyroid cancer? Thyroid cancer is the most common endocrine malignancy for women, and it has a rising incidence globally. And no previous studies had evaluated the association of night shift work and thyroid cancer, but we know that the circadian system and sleep regulates thyroid hormone production and release, and that night shift work and sleep deprivation has been associated with higher TSH levels and benign thyroid disease. So for this analysis, we used data from the Nurses Health Study 2 that recruited over 100,000 US registered nurses at baseline, so in 1989. Nurses filled out questionnaires every 2 years and returned these questionnaires on a wide range of exposures, new diseases, but also sociodemographic, lifestyles, etc. At baseline, the total years of rotating night shift work was reported and was updated almost every 2 years throughout the follow-up, as indicated in the timeline here. And thyroid cancer was reported in the biennial questionnaires and then was confirmed after with participants' permission by a study physician. So in total, in this analysis, 588 incident thyroid cancer cases were confirmed. And sleep was assessed in 2001, so this is 12 years after the initial assessment of shift work. So although we found no significant increase in the risk of thyroid cancer with night shift work, so this is the main analysis, independent of the shift work duration. So these are tertiles of night shift work duration, low meaning fewer years and high meaning more years of night shift work experience. When we stratified by sleep duration, we observed that night shift workers with reported low and high sleep durations were at an increased risk of thyroid cancer, and some of these differences were statistically significant, which is somewhat in line with our previous findings on gastrointestinal tumors. And similarly, when we also found that report of sleep difficulty or sleep disturbances all or most of the time among night shift workers also led to an increased risk of thyroid cancer compared to day workers. So this again here was a suggestion that there is a potential exacerbation of the basal risks with extreme sleep duration or when poor sleep is experienced and reported. So contrary to the previous study, here the assessment of sleep followed the assessment of shift work, and therefore we could establish a causal association between shift work and sleep, but also the analysis was prospective analysis, so therefore the disease endpoints, in this case, thyroid cancer, was observed after the assessment of the exposures. And basically, traditionally, in shift work analysis in studies of cancer, have been adjusted for sleep variables in order to account of potential confounding, as you see here on the top with the green, highlighted in green. But we believe that confounding is rather unlikely in this case. So it's more likely that disturbances in sleep disturbances and difficulties with sleep are rather underlying mechanisms or mediators of the night shift cancer link, and therefore mediation analysis would be more appropriate. In our data, additional adjustment of shift work models for sleep variables only minimally changed the estimates, therefore did not support confounding of the overall effects. On the other hand, we found evidence for effect modification and increased thyroid cancer risk among night workers who developed sleep disturbances. So if sleep disturbances can modify the risk of chronic diseases, then preventing and treating them may have a great potential for cancer and chronic disease prevention through sleep training programs tailored to shift workers, sleep interventions, sleep hygiene, as well as early diagnosis and treatment of sleep problems. So to summarize the first part of my talk, night shift workers with short and long sleep hours were at an increased risk of colorectal and gastric cancer compared to night workers with 7 hours of sleep in the first study. And in the second study, night work was associated with thyroid cancer among workers with extreme sleep durations and sleep difficulty. So the impact of joint effects of night work with sleep disturbances requires further investigation in future epidemiologic and mechanistic studies. And this brings me to the second part of my talk, which is more related to the biological mechanisms underlying the carcinogenicity of night shift work. So there is a number of partly interrelated biological mechanisms and pathways that have been examined, both in the lab and in the field, including suppression of nighttime melatonin production by light at night exposure, changes in sex hormone levels, also partly mediated by lower melatonin production, adverse metabolic changes, alteration of expression of circadian genes, and a lot of work. Our group has done quite a lot of work in this area in field studies. The ICOH evaluation of the carcinogenicity also concluded that we have limited human evidence of biological mechanisms in humans and that more mechanistic studies are needed. However, mechanistic studies in the field, in real-world settings, are laborious or challenging and very difficult to conduct. So this is, again, an old study I did back in the day when I was at ICOH Global in Barcelona, where we used melatonin, which is a marker of melatonin and markers of melatonin rhythm, which is a reliable marker of the circadian phase and the timing of the circadian clock. And this has been used in field shift work studies, like this one that we conducted together with Manolis Koyevinas and others from ICOH Global. So in this study, we collected natural urine samples over 24 hours, and we estimated the urinary 6-sulfatoxymelatonin, which is the main metabolite of melatonin, which is a reliable marker of melatonin rhythm. It's non-invasive and it's convenient for field studies of shift workers. So we then conducted cosinor analysis, which is a rhythm analysis that gives information on rhythm parameters, such as the mesor, which is the mean levels of the metabolite, and acrophase that represents the peak time. And here you can see the comparison of these parameters between night and day workers. So in total here we had 117 workers. I'm not going to go into the very details, but I just want to show you that night workers experienced lower levels of melatonin, but also experienced this 3-hour phase delay in the production of 6-sulfatoxymelatonin. So overall, we have the small phase delay indicating partial adaptation. However, when we look into the same data by occupational sector, and here you can see that in this study we had 36 night workers from a hospital setting, 18 night workers from car industry, and 18 workers from a railway company. We find differences in the acrophase, and you can see that the delay is much larger among night workers in the railway company. And these night workers were working on different shift schedules, and specifically railway company workers, they had more intense shift schedules with up to 5 consecutive nights. Whereas, for example, the hospital nurses, although they were permanent night workers, they didn't exceed the 3 nights in a row. So you can see that the impact of shift work schedule and shift work metrics is quite big when it comes to changes in melatonin, which is an indication of shift work adaptation. So to overcome some of the issues with inter-individual variability in some of these markers between workers, and also account for some of the influencing factors like the ones mentioned before regarding the different schedule, we conducted the second study. And here we recruited 51 male rotating night shift workers from a car company. And these workers were working on a slow backward shift schedule. So workers rotated every 3 weeks between the night, morning, and evening rotation in this direction. And they had 5 work days and 2 days off. And they participated twice in the study, on a day shift and on a night shift. And we tried to recruit participants on the 2nd or 3rd week of their rotation. So all the workers provided information through questionnaires, but also gave blood samples before and after each shift. And they also provided natural urine samples over 24 hours, again, for melatonin estimation. And they also wear a light sensor and an active watch for assessing sleep and activity patterns. So here are some of the socio-demographic characteristics of this study population. As you can see, they were relatively young. Half of them were overweight or obese. More than half of them were former or current smokers. And they had a mean experience of night shift work of 10 years. And a quarter of them were diagnosed with a chronic disease. So in the different biospecimens collected in this study, hormone analysis were conducted in the urine samples, and blood samples were used for immune marker analysis and metabolomic marker analysis. And the basic difference of this with the previous one is that here we're able to conduct intra-individual comparisons with day shift being the reference category. So here we found a much greater delay in the melatonin production. So it was about 9 hours later in the night shift compared to the day shift, which was an indication of an average higher circadian adaptation to the night shift, as would be expected in this slow rotation. But in addition to that, several of the peripheral clocks were also shifted, and so we also found evidence of delay in the production of some of the sex hormones, which was also found in the previous study. Now, despite the relatively high degree of adaptation, the levels of melatonin were still lower in the night shift compared to the day shift, and the levels of sex steroids were higher in the night shift compared to the day shift. And in addition to that, we also found evidence of immunosuppression. I'm not showing you the results. The 3 papers are published, just summarizing the results. We also found a pattern of immunosuppression on the night shift compared to the day shift. And also several metabolic markers were perturbed. So altogether, despite these workers being relatively well adapted to their night shift, there was a series of impaired biomarker profiles for hormones, immune, and metabolic markers in these workers. Next, within the same study, we wanted to examine predictors of adaptation to the night and day shift separately. And we also wanted to see whether the degree of adaptation, the better or worse adaptation, also resulted in less or better biomarker profiles. So to do that, we took the main period of melatonin production, defined as the interval at which the levels rose to 75% and then dropped to 75% of the peak. And we also used the sleep onset and offset times measured with the actigraphy devices. And we constructed this adaptation index as the overlap between the main melatonin production, the sleep period, based on some previous work done by Heidi Lammers et al. And so here you can see the light exposure, you can see the melatonin curve, the sleep period, and the melatonin peak period, and we were taking the overlap of these two. So as you can see, with our definition of adaptation here, which was taking into account not only the melatonin production, but also sleep in conjunction, we found evidence of relatively low overlap between melatonin production and sleep, and the adaptation was worse to the day shift, because although these workers worked they were rotating shift work, so once they adapt to the night shift, then they have to go and adapt back to the morning shift and then to the evening shift. So there's a constant change of internal circadian timing. So we evaluated factors that as predictors of adaptation that were stable throughout the rotation, such as, for example, age or chronotype and education. And then we also considered several behavioral factors that are shift specific. and may change when workers work on the day shift versus the night shift. And therefore, we evaluated these shift-specific sleep activity, light and meal timing factors. And to focus on the most relevant predictors to include in the subsequent multiple linear regression models, we selected only those variables which were associated with the adaptation variables in single regression models. And we did separate models for night shift adaptation and day shift adaptation. So then we applied multiple linear regression models adjusted for age and daylight duration to determine which predictors were associated with differences in adaptation during the night shift and during the day shift period. And we found that during the night shift, later chronotype, more light exposure during the night were associated with worse adaptation, while longer sleep duration was associated with better adaptation. So for the day shift period, a later bedtime was associated with a worse adaptation, while longer sleep duration was associated with a better adaptation. Perhaps not all of this makes sense to you, but we next tried to see whether the degree of adaptation mattered in relation to the biomarkers that we had previously seen were associated with this shift work schedule. And although we found no clear association pattern between shift work adaptation, the way we defined it, biomarkers of disease risk, there were some suggestions for higher androgen levels, higher levels of inflammatory markers, and lower levels of some metabolite markers in less adapted individuals in the night shift. So to summarize the second part of my talk, within our study population of slow backward rotating night shift work schedule, we found several factors, including chronotype, sleep timing, sleep duration, light and meal timing, to be related to night and day shift adaptation. The night shift schedule was associated, this night shift schedule was associated with biomarker changes from hormones to metabolites. And some biomarkers appeared at different levels in better adapted individuals, but overall, no clear association pattern with this definition of adaptation. So these results may help inform similar studies or non-pharmacological interventions at the workplace to enhance or avoid circadian adaptation of shift workers as needed. And in the last few minutes of my talk, I would like to introduce briefly the Shift to Health project, which started in 2023. It's a 5-year project funded by the EU with the participation of 15 partners in 6 countries in Europe, with the aim to develop and evaluate nutritional strategies to prevent obesity in night shift workers. And some work has already been done. So we conducted this online survey in 8 countries in Europe to gain insights in shift work schedules, health, well-being, but also diet and sleep. And recruitment was challenging, but it's done. So now we are analyzing the data. And at the same time, we are currently recruiting participants for a biomarker-based cross-sectional study. That is the first phase of this project, where we are, similar to the studies I showed you before, we are recruiting night workers and day workers from the health sector and different industrial sectors in 5 countries, aiming for a total of 1,000. So for a mega cohort where we will be able to analyze anthropometry, dietary behavior, mental health, sleep perception, but also a wide range of biomarkers, including the gut microbiome, oral microbiome, metabolomics, glucose metabolism, hormones, inflammation, and so on. And so right now we are trying to get the participants for a study, which is also very extremely challenging for a very complicated protocol like this one, and expect and hope to be able to present to you some results on this very soon. And we're also conducting a mechanistic study where we are going more in depth. So here we're also collecting information using actigraphy for sleep and activity. And we are collecting additional samples here, urine, 24 hours, again, for melatonin suppression. And also we're collecting this tongue swab collection and repeated dried blood samples for metabolomic analysis. And we're also planning 2 interventions, but this pertains to the future, so I will keep that for another time. With that, I would like to thank all my collaborators from different studies, different institutes, And before I end, I'd like to introduce you to the Working Time Society and our new website. This is the sister organization of the Scientific Committee on Shiftwork and Working Time. Check out our activities, follow us, become members, and please take advantage of the extended submission deadline to participate in our next symposium, which is in Brazil in 2025. So I hope to see many of you guys there. And the last slide on an ICE Global course on circadian rhythms and health, which I have the pleasure to organize, coordinate together with Camille LaSalle and also teach. And this was distributed, so I hope to see this edition of this course this time in Spanish. We have previously held 2 editions in English. So I hope many of you have taken the opportunity to register, and we will hope to see many of you in 2 weeks from now. Thank you very much for your attention, and I'm happy to take questions.
Thank you, Dr. Kyriaki, for such a great presentation and sharing with us all your research and experience. And we would like to invite the attendees to make some questions. Dr. Kyriaki can do her presentation in English, but also she can speak Spanish. So please feel free to make questions. Okay. Well, I would like to start, Dr. Kyriaki. You just mentioned about non-pharmacological strategies at the workplace to enhance or avoid circadian adaptation. Especially you talk about the sleep light and circadian interventions. Which of them would you recommend us to start working with? It's a company where there is no prevention culture and we have to start from zero.
Yeah, that's a great question. I would say light and sleep hygiene is a good place to start. I think we have good evidence that optimally timed light can help workers to shift their clock to better adapt to the schedules. But the question is how much and when, right? And I think that to properly answer the question, I would say you need always to check at the shift schedule and see how many nights in a row you have. So if you have a slow rotation schedule like the one I was presenting earlier, then you may need to consider bright light to help shift workers adapt. But the question remains, how far do you want them to go? Because then you need to bring them back. So with light is a chronobiotic, and we know that depending on when we administer light, we will get a certain result. So light later in the evening will delay the rhythms, and light in the earlier in the day will advance the rhythms. So I think light is a good place to start. And then sleep is another good place to go with shift workers. So when do they sleep? Perhaps you want to ask them what sort of sleep do they have? Do they have split shift, or do they what do they do before it's night shift, or when they have or after the night shift when they want to go back to the day shift orientation, and so on, and give some advice based on the sleep timing. And I would say these were the places where I would feel there is more evidence that we can already take some actions, like from research actually to implementing some of this into recommendations. And then, yeah, because these are the things you can change. Of course, there's a lot of changes that can be done on the scheduling level, so to change the shift schedules. But when you cannot change shift schedules, then it's up to the workers to take individual measures. Then I would say that's a good place to start.
Thank you, Dr. Kyriaki. We have one participant, Dr. John Ewer, who would like to make a question.
Yes, John, you are here in Chile. Thank you for the presentation. I was wondering why you decided to measure melatonin and not like body temperature, which is in a way simpler, using these sensors that you can swallow. And the other question was, this is like a technical question. When you do the Cosino analysis, do you force a 24-hour periodicity and look at the amplitude for 24-hour rhythms, or do you ask the program to look for any rhythm and hope that it's close to 24? Because sometimes people have a rhythm, but it's not circadian, and so you really don't know what to do with it.
Okay, thanks for the questions. I will start with the second question. And the answer is that with the cosigner analysis, yes, we do force the rhythm to 24 hours, but I think that's quite reasonable to do. And we also check how well is variability explained. And for example, for melatonin, you have a really good, you get good scores there, but we tried it for other metabolites, for example, for the sex hormones, and there you don't get a good fit, basically for the sex hormones, and even for cortisol, you don't get a good fit either, because there is no, so the rhythm does not go 12 hours up, 12 hours down. So this is what I remember from the cosigner analysis back then. And regarding the question of melatonin, I don't recall back in the day to have heard about the pills that you swallow. So have you used, I would then return the question to you and perhaps ask you, have you used this in Shiftwork studies or in any studies,
Yes.
like with the swallowing of the pills? I've heard of it recently.
Yeah, so these were pills that,
Could you perhaps share your experiences?
yeah, it's pretty interesting. So so these pills were developed by NASA for astronauts, and they're now commercially available. And they're little pills that are more or less the size of those pills that have gelatin in them, and they have a sensor, a temperature sensor, and an emitter that then emits the data to a little bracelet. And they can be programmed to emit the temperature like every minute or every 2 minutes or every 10 minutes, I forget. And either one, I mean, all of those. And then the other beauty they have is that they store the data. They store several points. If the person, say, takes the watch off to take a shower or whatever, and so when you put the bracelet back on, it takes the data. And they're precise enough that you can measure the temperature rhythm, which is only around 1 degree. And we've been working with people on night shift who are drivers in Chilean mining, where they have 7 days of night, 7 days of rest, 7 days of day work, and 7 days of rest again. And then they repeat the cycle. And during the night shift, what we found was that many of the workers don't have a rhythm at all. And those that do have a rhythm that is sometimes non-circadian. So they might have a 18-hour rhythm. And I don't know how to interpret that, but it's clearly not relevant to anything circadian. So it's a very untidy situation for them. And these things work very well. And they will, well, eventually this capsule is lost, but they will transmit for as long as the pill is in the body. And the beauty is that they measure core body temperature.
Okay, thanks. Yeah, I must say that when we were doing this study, we were collaborating with Deborah Skeen, who was a professor of chronobiology in the University of Surrey, and they had developed the radioimmunoassay for 6-sulfoxymelatonin. And back then, it seemed to us a gold standard method for tracking the rhythms. And I think like doing the 24-hour urine was, at the time, it was quite of an effort, but it worked really well even when workers had to do remote work and things like that. So
yeah, it's just difficult for these workers who are drivers.
Sure. So it's a good alternative. Yes, thanks for the insights.
There's several companies. One is a
Absolutely.
French company, and I think there's an American company in Florida.
Nice.
Thank you.
Thank you, Dr. John. We have one question in Spanish. It's not so long. For shift workers, well, maybe you can read it, Dr. Kiriaki. ¿Debería haber una intervención psicológica o un soporte nutricional for these shift workers? Would it be necessary, support from psychological therapist or maybe nutrition advisor?
Yeah, this is a great question. Puedo intentar contestar para la parte de salud mental, tal vez yo no soy la mejor persona en contestar porque no he trabajado mucho en este área de investigación y diría que no sé muy bien si han habido intervenciones psicológicas en trabajadores de noche, pero en la parte de soporte nutricional es algo que nos interesa y estamos evaluando en este momento en el proyecto de Shift to Health, en este proyecto europeo que mencioné, donde estamos trabajando muy cercamente con nutricionistas y la parte de la nutrición y de la crononutrición tiene un papel muy central, tanto en el estudio que estamos haciendo ahora, que con biomarcadores tenemos muchos recogida de datos nutricional, pero también estamos planeando una intervención con un enfoque nutricional utilizando suplementos dietéticos que tienen un potencial cronobiótico. Y ya sé que no se va a solucionar el problema de los trabajadores de noche con una píldora, pero yo creo que a través de este proyecto vamos a poder contestar mejor preguntas sobre la nutrición. Sé que hay mucha evidencia que en estudios experimentales y algunas en el campo que están mirando el tema del fasting, no sé cómo se dice en español, de no comer durante el periodo nocturno. Y ahí se ven beneficios a la salud cardiovascular en trabajadores que tienen un periodo de fasting más largo. Entonces, yo creo que ahí también hay un potencial de intervenir y mejorar la salud metabólica de los trabajadores de noche.
Thank you, Dr. Kiaki. We have a very short time just for the last question from Dr. Michelle Caruño before we start with our second speaker. Please, Dr. Michelle.
Yes, thank you very much. Thank you, Dr. Papantonio, for your great talk. I was very fascinated by I'm Michele Caruño from University of Milan, Italy. I was very fascinated by the concept of maladaptation that you talked about. And at a certain point, you said that the sleep duration might be a possible marker of maladaptation. Also, your results showed that later chronotype basically was a possible predictor, right? And so you introduced the hypothesis of sleep hygiene as possible interventions to ameliorate, let's say, the adaptability of the workers to night shift work. But I was wondering whether you had researched on possible biological markers of adaptation that you might have looked into, such as obviously the first thing that comes to mind is sleeps, but also there's you worked on or you know about. Thank you.
Yeah, thanks for the question. I think sleep probably holds a great potential in identifying the susceptible workers. Is probably a better indicator of maladaptation than chronotype. Several years ago, it was hypothesized that chronotype will tell us who is more suitable for night shift work. But from my experience looking into different data sets and testing the chronotype hypothesis, I didn't present this today, but I am not so convinced about assessing chronotype to test which workers would be more suitable and would be more safe and would be better off in relation to chronic disease risks. Perhaps they're better off in the short run, but in the long run, late chronotypes do not seem to be protected by any of the chronic disease risks that we are observing. Therefore, I feel more optimistic about sleep in that we can assess sleep. I think even occupational physicians could consider asking about sleep, diagnosing sleep problems, and treating workers with maladaptation assessed as poor sleep or short sleep. My experience is also that shift workers often consider poor sleep as part of their job. Therefore, they're also less likely to seek help and to normalize sleep problems as part of their job. So therefore, we have even greater underdiagnosis of sleep disorders in shift workers. So I do believe that that sleep is a marker per se. It's not a biologic marker, but we have good ways to assess sleep, both objective and subjective ways of assessing sleep. So I would say, while we don't have a better cheap marker like that we can routinely assess, I would say sleep is a safe place to start.
Thank you, Dr. Kyriaki. Thank you, Dr. Michel, for your participation. And well, great to have you here, Dr. Kyriaki. We appreciate your contribution to this webinar. So now it is my pleasure to introduce you to our second speaker. I am sharing the presentation. So Dr. Malena Moore-Ferrer holds a degree in biotechnology and a PhD in science and technology. She is currently an assistant researcher at the Chronophysiology Laboratory of the Institute for Biomedical Research in the Universidad Pontificia de Argentina in Buenos Aires, Argentina. She has been working in biological rhythms research for almost 15 years, initially with rodent models and now with human participants. Her research focuses on understanding the impact of circadian rhythm disruption, particularly in the context of non-traditional work schedules, on sleep quality, cognitive function, and overall health. So welcome, Dr. Malena. I will make you the host so you can share your presentation.
Okay, thank you, Norville. And here. ¿Pueden ver la pantalla completa o
Sí.
simplemente el PowerPoint?
¿Ya cargó?
¿Sí? ¿Está completa?
Sí.
Perfecto. Uy. Ahí, ok. Ah. Tuve un problema. Ahí está. Bien. Bueno, buenos días, buenas tardes, buenas noches a todos, a todas. Antes que nada, quería agradecer al International Commission of Occupational Health por invitarme a estar hoy acá. Es un placer poder estar dando esta charla. Como decía Norville, mi nombre es Malena Mulfedele y soy parte del Instituto de Investigaciones Biomédicas del Laboratorio de Cronofisiología en Buenos Aires, Argentina. Y les voy a estar contando acerca de un estudio que realizamos analizando el sueño y la fatiga de los trabajadores que trabajan en diferentes esquemas laborales, que son esquemas laborales no tradicionales, por lo menos para la fuerza laboral acá en nuestro país, en Argentina. Bien, entonces como la mayoría de ustedes deben saber, vivimos en una sociedad llamada, ok, la podemos llamar 24/7, porque tanto las demandas empresariales, socioculturales e industriales de esta sociedad actual corren alrededor de las 24 horas del día y entonces eso hace que tenga un efecto, un impacto negativo en muchas variables y sobre todo en nuestro descanso, en nuestro sueño. Y esto nos lleva al desarrollo de, entre muchísimas cosas, de la fatiga. ¿Sí? A corto plazo podemos hablar del desarrollo de fatiga a causa de esta sociedad 24/7. Y llamamos fatiga al estado de rendimiento físico o mental reducido, que puede ser como resultado de múltiples variables y de la intersección de todas esas múltiples variables, pero nosotros nos vamos a enfocar en este caso en los desórdenes de los ritmos circadianos, de nuestro reloj circadiano, la alta carga laboral y la falta de sueño o la vigilia prolongada. Y lo que sabemos hace muchos años, a partir de un estudio realizado por el grupo de Dawson, es que los síntomas de la fatiga pueden compararse y son similares a la ingesta de alcohol. De hecho, sabemos que el hecho de estar despierto por 17 horas o más puede ser equivalente a tener un contenido de alcohol en sangre de 0,5 gramos por litro, lo cual en muchos países de Latinoamérica es el límite para poder conducir, y en algunos otros, o en algunas áreas de esos países, todavía es menor el límite para conducir. Y obviamente si hablamos de conductores profesionales, no puede haber alcohol en sangre, ¿sí? Por lo cual ese límite es de 0. Y muchos estudios al día de hoy muestran que entonces entre el 10 y el 30% de los accidentes laborales pueden atribuirse a errores asociados con la privación de sueño. De hecho, si nosotros vemos los informes técnicos de tragedias como la de Three Mile Island, la de Exxon Valdez, la explosión del Challenger o Chernobyl, lo que podemos analizar es que uno de los factores que podrían haber contribuido a estos accidentes es la fatiga del personal que estaba a cargo en ese momento, ¿sí? Porque ese personal no había descansado lo suficiente o en el horario que es el correcto, ¿sí? El propicio para llevar adelante el descanso. Entonces, nosotros en un estudio que realizamos ya hace unos años, lo que hicimos fue analizar la relación entre las características del sueño y laborales de médicos residentes con los errores médicos que estos médicos reportaron. Y entre algunos de los resultados que obtuvimos, en un análisis multivariado, lo que vimos fue que tanto la duración de su jornada laboral más prolongada, ¿sí? Que generalmente son las guardias, como la cantidad o el hecho de tener más de 6 guardias mensuales, de realizar más de 6 guardias mensuales, y el hecho de dormir menos de 6 horas durante los días laborales, pueden considerarse predictores de estos errores médicos. Y si vamos específicamente al sueño, perdón, ahí está. Lo que observamos es que aquellos médicos que informaron haber tenido un error médico durante el estudio, ¿sí? Que son los que podemos ver en gris, durmieron más durante el día, si tenían más sueño diurno y menos sueño nocturno que aquellos médicos que informaron no haber tenido errores durante el mes que nosotros realizamos el estudio. Todo esto es realizado mediante actigrafía, ¿sí? Más adelante nos propusimos a realizar este estudio que les comentaba al principio, en el cual examinamos las características circadianas y la fatiga de 3 esquemas laborales distintos, pero esta vez en trabajadores de una industria petrolera de nuestro país, de Argentina. Estudiamos 3 condiciones laborales distintas. El esquema 1, que también lo llamamos 2x2x4, es aquel en el que los trabajadores realizan 2 jornadas desde las 7 de la mañana a las 7 de la tarde o de la noche, seguidas por 2 jornadas desde las 7 de la tarde hasta las 7 de la mañana y luego 4 días de descanso. El otro esquema que analizamos, el esquema 2, también llamado 4x4x4, es aquel en el que los trabajadores realizan jornadas desde 7 de la mañana a 7 de la tarde, ¿sí? 4 jornadas seguidas, diurnas. Luego tienen 4 días de descanso y luego realizan 4 jornadas desde las 7 de la tarde a las 7 de la mañana de manera continuada y nuevamente tienen 4 días de descanso para volver a arrancar, ¿sí?, con este esquema. Y por último, el tercer esquema, que es el de las 12 horas fijas, en el cual los trabajadores tienen jornadas de 12 horas desde las 7 de la mañana hasta las 7 de la tarde durante 30 o 40 días continuados, sin ningún tipo de descanso. Entonces, en este caso, analizamos a 44 trabajadores en turnos no convencionales, todos masculinos, porque no hay mujeres trabajando en estos puestos, en esta industria. Durante 15 días estos trabajadores llevaron un actímetro, entonces pudimos realizar actigrafía y además estos mismos relojes, estos mismos actímetros tienen la posibilidad de medir la temperatura periférica, ¿sí?, la temperatura de la misma muñeca de los trabajadores. Y asimismo también realizamos cuestionarios online en los cuales los trabajadores completaron acerca de sus datos demográficos, sus datos laborales, el impacto de la fatiga en sus actividades diarias, el nivel de alerta percibido y de rendimiento. También completaron un índice de severidad de insomnio, un índice de stop band, que es para el estudio de las apneas, la escala de somnolencia de Epworth y el inventario de ansiedad y de depresión de Beck. Cuando analizamos las características sociodemográficas de estos trabajadores, no vimos diferencias. Sí, lo que observamos es que en todos los grupos había un gran porcentaje de trabajadores con sobrepeso y con obesidad. En cuanto a actividad física y consumo de bebidas cafeinadas, no observamos diferencia, pero sí observamos que aquellos que trabajan bajo el esquema 4x4x4 tienen más tiempo de viaje para llegar al trabajo y a su vez hay un porcentaje mayor de estos trabajadores que presenta un segundo trabajo adicional a este trabajo principal en la industria petrolera, que lo realizan en sus días libres. ¿Sí? Entonces, tanto este tiempo de viaje, ¿no?, como la presencia de este trabajo adicional, obviamente pueden estar afectando su tiempo para descansar. Cuando vamos específicamente a analizar las características de sueño, que como ya les mencioné previamente, lo hicimos mediante actigrafía, estudiamos el sueño tanto entre las jornadas diurnas, o sea, entre esas jornadas que realizan desde las 7 de la mañana y las 7 de la noche, entre las jornadas nocturnas y en sus días libres. Y lo que observamos es principalmente, y lo más importante es que los trabajadores en todos los esquemas, cuando hacen jornadas laborales diurnas, duermen menos de 6 horas, ¿sí? Tanto para el caso de 2x2x4 y 4x4x4, que como ven están durmiendo 5 horas 10 o 5 horas 42 en promedio. Y los trabajadores que realizan el esquema de 12 horas fijas también duermen muy poco y menos de las 7 u 8 horas recomendadas para un adulto, ya que duermen en promedio 6 horas y 20. Y si vamos a los resultados de la estadística, lo que podemos observar es que aquellos que realizan el esquema de 4x4x4 duermen significativamente menos que los que realizan el esquema de 12 horas fijas diarias. Cuando analizamos el sueño entre las jornadas nocturnas, no vimos diferencias entre los grupos. Obviamente que en este caso el esquema de 12 horas fijas no lo pudimos analizar porque no realiza jornadas nocturnas, pero lo que sí vimos es que el periodo de sueño es realmente muy corto y menor a las 4 horas, ¿sí? Entonces, entre las jornadas nocturnas duermen durante el día y obviamente este periodo de sueño durante el día se acorta muchísimo. Y cuando vamos a estudiar el periodo de sueño en los días libres, que obviamente en este caso tampoco participa el grupo de 12 horas fijas porque no tienen días libres durante el periodo de análisis, lo que vemos es que tienen, sí, obtienen la cantidad de sueño recomendado, pero uno esperaría que en estos días libres ellos recuperen la deuda de sueño que se está generando durante la semana, durante los días, perdón, durante los días laborales, pero esto no es así, ya que duermen, en el caso de los 2x2x4, 8 horas, ¿sí? En el caso de los 4x4x4, 7 horas y media, es decir, no están durmiendo horas de más de las horas recomendadas. Y además lo que vemos es que los del esquema 2 duermen significativamente menos que los del esquema 1. Bueno, analizamos también las siestas. No vimos diferencias entre los grupos en la duración de las siestas. Lo que sí vimos es que las siestas principalmente ocurren en los días en los cuales trabajan durante la noche. Y que en los días libres también obtienen siestas, pero no son tan prolongadas como en la en los días entre jornadas nocturnas. Cuando analizamos el horario medio de sueño entre las jornadas laborales diurnas, lo que vemos es que aquellos que realizan el esquema 2, el 4x4x4, tienen un horario medio de sueño más temprano que los otros dos esquemas. Esto significa que se van a acostar antes. Sin embargo, cuando lo analizamos para en los días entre las jornadas nocturnas o para los días libres, no hay diferencia entre el esquema 1 y el esquema 2. Y en el caso del índice de regularidad de sueño, que es un índice que nos indica cuán regulares son los horarios de sueño de estas personas, cuanto más cercano al 100, más regular son los horarios, lo que vemos es que obviamente los que tienen el índice, tienen una mayor regularidad son los del esquema de 12 horas fijas y la menor regularidad la tienen, ¿sí?, los del esquema 1. Y por último, en cuanto a somnolencia no vimos diferencia, en cuanto a síntomas relacionados a las apneas tampoco, pero sí lo que observamos es que para los síntomas relacionados al insomnio, aquel esquema 1 o bajo el esquema 3, reportaron tener más síntomas de insomnio que los del esquema 2. Entonces, esta figura que les muestro acá es para analizar un poco más gráficamente cómo es cada noche de sueño, perdón, cada periodo de sueño, ¿sí?, a lo largo de los días, que podemos verlo en el X, en el eje Y tenemos las horas de sueño, y como se ve, ¿sí?, acá claramente la curva amarilla es la que pertenece al esquema 2x2x4, la que muestra los datos del esquema 2x2x4, cuando estos trabajadores realizan jornadas nocturnas, el periodo respecto a nocturnas, aún sí, libres, y lo mismo sucede, ¿sí?, con aquellos que realizan el esquema 4x4x4, que se ve en la curva verde, cuando hacen las jornadas nocturnas, la cantidad de sueño disminuye muchísimo respecto a las jornadas diurnas y a los días libres, y también respecto al sueño que obtienen los del otro esquema. Y en los box plots de abajo, sí, se ve lo mismo, pero obviamente realizando un promedio, sí se ve la diferencia entre el sueño obtenido entre las jornadas diurnas y las jornadas nocturnas. Y lo que vemos en la figura esta de la derecha es el horario medio de sueño, donde podemos observar que los días laborales, aquellos que realizan, perdón, los trabajadores que realizan tanto el esquema 2x2x4 como el 4x4x4, su horario medio de sueño, ¿sí?, se adelanta casi 2 horas en comparación con los días libres. ¿Sí? Esto significa que están adaptando su horario de sueño, o podríamos decir su cronotipo, para poder adaptarse, ¿sí?, valga la redundancia, al esquema laboral que deben realizar. Bueno, como les decía, también analizamos el ritmo de temperatura. y lo que observamos fue que aquellos que realizan el esquema 2x2x4 tienen un ritmo de temperatura menos, sí, menos fuerte, sí, más débil. Lo que vimos es que la amplitud, ¿sí? Del ritmo de 12 horas de temperatura y la fortaleza del ritmo es más baja para aquellos que realizan este esquema comparado con los que realizan el esquema 4x4x4 y los que realizan el esquema de 12 horas fijas. Entonces esto está dando cuenta de cómo los esquemas están impactando distinto, ¿sí? Sobre el reloj circadiano de estos trabajadores. Y por último, yendo a los reportes subjetivos de fatiga y cómo la fatiga impacta en el rendimiento o cómo ellos perciben que impacta en su rendimiento, le preguntamos cómo ellos veían o en qué factores, en qué actividades diarias ellos veían que la fatiga estaba teniendo un impacto negativo, y para que lo puedan observar mejor, acá resumí aquellas actividades en las que vimos diferencias significativas. Y lo que observamos, en resumen, es que los trabajadores bajo el esquema 1 y los trabajadores bajo el esquema 3 reportaron que la fatiga reportaron tener un mayor impacto negativo de la fatiga en el aprendizaje de nuevas tareas, en su satisfacción como trabajadores de esta empresa, relación con compañeros, ¿sí? Ellos reportaron tener un mayor impacto de la fatiga, como pueden observar, mientras que los del 4x4x4 no perciben tener ese impacto en estas actividades diarias. También les consultamos sobre cómo ellos percibían que era su nivel de alerta para llevar adelante las tareas a la mitad del día y a la mitad de la noche. Y nuevamente, los que realizan el esquema 1, el 2x2x4, perciben que tienen un menor nivel de alerta a mitad de la noche, ¿sí? A comparación con aquellos que realizan el esquema 4x4, que no perciben tener un nivel tan bajo de alerta a mitad de la noche. Asimismo, ¿sí? Tanto los trabajadores del esquema 1 como del esquema 3 reportan estar significativamente cansados, ¿sí? Más días en los cuales experiencian un cansancio significativo, ¿sí? Que es lo que les preguntamos, es cuántos días en el último mes habían experienciado fatiga significativa, y tanto los del esquema 1 como los del esquema 3 reportan más días de fatiga significativa. Y relacionado con las variables psicoafectivas, no vimos diferencias en el reporte de síntomas de ansiedad, pero sí en el reporte de síntomas de depresión, ¿sí? Nuevamente, los del esquema 1 y los del esquema 3 reportan más síntomas de depresión que los del esquema 2. Entonces, para hacer un resumen, ¿sí? Si vamos a de turnos rotativos, lo que observamos es que el esquema 4x4x4, ¿sí? Presenta menos horas de sueño que el 2x2x4 cuando lo analizamos objetivamente mediante actigrafía, pero sin embargo, la regularidad de sueño, ¿sí? Estudiado por el índice de regularidad de sueño, que lo calculamos también con estos datos objetivos, es menor para el 2x2x4 que para el 4x4x4. Es decir, los del 4x4 duermen menos, pero tienen una regularidad mayor. A su vez también, 4x4 reportan menos síntomas de insomnio que los del otro esquema, esto relacionado al sueño. Y relacionado al reloj circadiano, lo que vemos cuando estudiamos el ritmo de temperatura es que la robustez del ritmo de temperatura es menor para los del 2x2x4 comparado con los del 4x4x4. Entonces, los del 4x4x4 estarían durmiendo menos, pero si nosotros estudiamos regularidad de sueño y robustez del ritmo circadiano, están mejor que los del otro esquema. Y esto entonces parecería, ¿sí?, que hace que tanto la fatiga, ¿sí?, como el nivel de alerta, como los síntomas de depresión sean mayores, ¿sí?, tanto el impacto de la fatiga como los síntomas de depresión para el esquema 2x2x4, y que entonces también perciban que tienen un menor nivel de alerta durante los turnos nocturnos. Entonces parecería que toda esta disrupción circadiana tiene un mayor impacto, ¿sí?, en la fatiga autopercibida y en el nivel de alerta, que el hecho de dormir menos. Porque además también pensemos que todos los grupos, todos estos trabajadores están durmiendo muy poco. Bien, entonces, esto es en cuanto a este trabajo en el cual hicimos este análisis comparativo de los esquemas laborales, pero nosotros sabemos que, bueno, esto es todo un panorama de cómo están los trabajadores en nuestro país, pero es necesario que sigamos trabajando para resolver esta problemática y encontrar soluciones, ¿no?, para poder detectar la fatiga a tiempo, para poder evitar errores y accidentes y para poder mejorar el bienestar y la salud de estos trabajadores. Por eso nosotros creemos que es importante trabajar en el desarrollo de los sistemas de manejo de riesgo de fatiga, también desarrollados por Dawson ya hace varios años, en el cual rápidamente les comento para aquellos que no los conocen. Es un esquema en el cual tenemos 3 capas para poder frenar los errores y los incidentes o accidentes relacionados a la fatiga. Es que en el primer escalón uno pueda proporcionar las oportunidades de sueño suficientes para que el trabajador pueda obtener el descanso necesario. En el segundo escalón se chequea el sueño obtenido y en el tercer escalón se chequean los síntomas relacionados a la fatiga. Entonces se pretende que a través de estos 3 chequeos uno pueda disminuir los errores y los incidentes o accidentes relacionados a la fatiga. Nosotros en este momento nos encontramos trabajando en este primer escalón y en el desarrollo de herramientas que nos permitan mejorar la organización de los esquemas laborales. Sabemos que es muy difícil cambiar los esquemas laborales hoy en día en nuestra sociedad, pero sí podemos hacer este tipo de comparaciones, como la que hicimos con estos trabajadores en industrias petroleras, y poder saber cuáles esquemas son mejores que otros o cuáles tienen un menor impacto en la salud y el bienestar de los trabajadores y la seguridad de los trabajadores. Y para ello lo que estamos utilizando son los modelos biomatemáticos de fatiga. Estos modelos biomatemáticos de fatiga son un conjunto de algoritmos que nos permiten determinar el riesgo de fatiga relacionado a un esquema de sueño-vigilia. Entonces esto nos permite diseñar esquemas de trabajo, jornadas laborales más seguras y de esta manera prevenir errores o incidentes relacionados a la fatiga. Estos modelos se basan, ¿sí?, en el modelo de 2 procesos de alerta, descrito ya hace varios años. Por un lado tenemos, ¿sí?, el proceso homeostático. A medida que nosotros, ¿sí?, nos despertamos, a la mañana en este caso, ¿sí?, se va acumulando presión homeostática, que lo que hace es que disminuya nuestro nivel de alerta. Cuando nos vamos a dormir, ¿sí?, hablamos de un tanque donde podamos acumular, entonces podría ser donde vamos a empezar a acumular alertas, ¿sí?, para que cuando nos despertemos nuestro nivel de alerta sea más elevado. Y por otro lado tenemos el proceso circadiano, ¿sí?, que es el que observamos acá en azul, que lo que hace es que nuestro nivel de alerta sea más alto durante el día y decaiga durante la noche. Entonces, cuando juntamos estos 2 procesos, o los algoritmos, ¿sí?, que describen estos 2 procesos, obtenemos esta curva punteada, ¿sí?, que describe el nivel de alerta a lo largo de las horas de vigilia de una persona. Entonces, lo que estamos haciendo, hoy en día existen muchos modelos cuyos algoritmos tienen parámetros que están ajustados mediante estudios que se realizaron en poblaciones específicas, entonces es posible que esos parámetros no se ajusten a todas las poblaciones y a todos los tipos de trabajo. Y entonces nosotros estamos trabajando en la optimización de los modelos, ajustando estos parámetros, ¿sí? Realizamos un estudio con otro tipo de trabajadores, en los cuales también existe privación de sueño. Lo que hicimos fue registrar actigrafía a lo largo de una semana y además tomarles test de rendimiento. En azul, sí, las curvas azules en este caso representan los test de rendimiento. La curva verde representa la curva de alerta predicha por los modelos biomatemáticos existentes al día de hoy. Como ven, en este caso, esta curva verde no se ajustaría a los niveles de alerta que nosotros medimos mediante los test de rendimiento, pero cuando nosotros entonces ajustamos los parámetros de el mismo modelo biomatemático que vemos en la curva verde, pero a esta población, ¿sí? A la población donde realizamos el estudio, obtenemos esta curva roja que entonces sí empieza a ajustar mejor a los datos de rendimiento obtenidos en esta población. Esto es cuando optimizamos los parámetros de manera grupal. Y en este caso, sí, a la derecha lo que pueden ver es la optimización de los parámetros de manera individual, donde vemos que entonces la curva también empieza, la curva roja empieza a ajustar mejor a los datos de alerta obtenidos en este caso. Bueno, aún estamos trabajando, estos son resultados preliminares de esta optimización de los modelos biomatemáticos de fatiga. Todavía no está publicado, pero bueno, esperamos que próximamente poder compartir con ustedes estos resultados. Bueno, entonces, para finalizar, agradecer nuevamente a la ICOH y agradecer a mi equipo de trabajo, pueden ver acá en esta foto, del Laboratorio de Cronofisiología, especialmente a Daniel Vigo, quien me acompaña en estos proyectos, en estos estudios, y a nuestros colaboradores del Laboratorio Interdisciplinario del Tiempo y la Experiencia, Diego Golombek y Leandro Casiray, y a nuestras fuentes de financiamiento, CONICET y Agencia. Bueno, muchas gracias y muchas gracias a todos ustedes por la atención.
Muchas gracias,
Y
doctora Malena.
cualquier pregunta, dispuesta a contestar.
Muchas gracias, doctora Malena. Felicitaciones por su presentación y compartir no solamente de su experiencia, sino también los proyectos que están ya en marcha. Muy interesante el modelo de optimización biomatemática de fatiga y creo que va a tener un impacto importante para la población laboral. Ah,
Esperamos que sí.
invitamos a los participantes para que puedan realizar alguna pregunta. Here we also have connected Dr. Kiriaki, so if there is anyone that would like to make a question in English or in Spanish and to make it translated into the other language, we can help you with the translation. Me gustaría comenzar haciendo una pregunta, doctora Malena. En el modelo de optimización biomatemática que están trabajando actualmente, hasta la fecha, ¿cuáles considera que son los principales limitantes o dificultades que han encontrado en toda la población que está participando en este estudio?
Bien, los modelos biomatemáticos de fatiga consideran solamente estos dos procesos que yo les mencionaba, ¿no? El proceso circadiano, que modela el nivel de alerta a lo largo del día manejado por el reloj circadiano, ¿no? Que está organizado por nuestro reloj circadiano, y el proceso miostático, sí, que tiene que ver con la presión homeostática de sueño. Pero obviamente hay un montón más de variables que afectan el nivel de alerta. Por ejemplo, la dificultad de la tarea que estamos realizando, ¿sí? La cantidad de horas que llevamos realizando la tarea. Uno solo está considerando la longitud del periodo de sueño, pero no estamos considerando la calidad de sueño, ¿sí? Entonces son muchos factores los que están afectando el nivel de alerta que hoy en día no están siendo considerados por estos modelados y que también hay que realizar más trabajo para poder agregar algoritmos que nos permitan ajustar el nivel de alerta a estos factores.
Perfecto. Gracias, doctora. Tenemos una pregunta del doctor John, que creo que podría hablar o en inglés o en español. El doctor John, por favor, si pudiera, lo voy a colocar, le doy el pase para que pueda tener el micrófono.
Sí, gracias Malena por la presentación aquí en Chile, John en Chile. Tenía una pregunta si tienes alguna interpretación por qué las personas que están en un ciclo horario en que claramente duermen poco, perciben que están en mejores condiciones que los que en realidad duermen más, que es el ciclo de 2x2, 2x2x4. Es bien curioso. Y
Sí,
y los números
sí,
eran grandes.
sí, sí, a nosotros también nos llamó la atención mucho la atención esto, porque de hecho esta gente pasa 4 noches seguidas trabajando durante la noche, durante 12 horas, lo cual es terrible, ¿no? Porque a la cuarta noche llegan realmente muy cansados, y sin embargo sí, perciben que están mejor. Eh, yo creo que en este caso los trabajadores en los tres esquemas están llegando a un límite, que ya, en el que ya como les mostraba, todos duermen muy poco, ¿no? Entonces sí, hay una diferencia. Los que están en el 4x4x4 duermen media hora menos que los del 2x2x4, pero aún así los del 2x2x4 también están durmiendo muy poco, porque duermen menos de 6 horas entre jornadas diurnas y duermen menos de 4 horas entre jornadas nocturnas. Y a esto además se suma la disrupción circadiana, que parece que está teniendo un efecto muy negativo, sí, o quizás más fuerte que la privación de sueño, ¿no? Están todos en un nivel en el que duermen muy poco y encima a ellos también se les suma que la disrupción circadiana pareciera ser mayor. Entonces, nosotros hipotetizamos que la disrupción circadiana está siendo mucho más fuerte, ¿no?, en estos extremos y está teniendo un mayor impacto en estos trabajadores que realizan el esquema 2x2x4.
Gracias.
No, gracias, John.
Gracias, doctor John. Tenemos una pregunta en el chat, doctora Malena. Eh, en el estudio mostrado de turnos, todos los trabajadores eran de la misma empresa, es decir, realizaban la misma actividad para poder ver si es que esto influye en la fatiga y el sueño.
Bien, en cuanto al esquema 1, que sería el 2x2x4 y el 4x4x4, sí, realizan exactamente la misma actividad, son actividades de monitoreo, son plantas en las cuales lo que monitorean el paso del petróleo, el paso del crudo, y lo que tienen es que ir, bueno, monitoreando que no pare el crudo en ninguna parte, salir al campo y separar los distintos tipos de crudo. Quizás en si se arruina alguna de las bombas que proporciona la fuerza para llevar el crudo hacia las plantas de refinamiento, también salir al campo a arreglarlas, pero tienen que estar todo el tiempo pendiente de muchas pantallas, muchas señales de alerta, tanto sonoras como visuales, y esa es su tarea. En el caso de aquellos que realizan el esquema de 12 horas fijas, tienen tareas de monitoreo, pero también tienen una mayor cantidad de tareas, que quizás implican más actividad física, porque tienen que llevar adelante el mantenimiento de la planta, porque estos trabajadores son aquellos que trabajan en lo que acá denominamos el paro de plantas, el paro de planta, que es cuando se para durante un mes o 40 días la planta en la cual trabajan para llevar adelante estas tareas de mantenimiento. Por lo tanto, las tareas sí son las mismas para los que realizan el esquema 1 y 2, pero no para los que realizan el esquema 3. Pero bueno, sin embargo, nos parecía que era lo más parecido a un control, ¿no?, de trabajo diurno, este tipo de esquema. Y en esta empresa no teníamos, solamente se realizan estos tres tipos de esquemas laborales, por lo tanto no teníamos otro punto de comparación, quizás más cercano a una jornada convencional de 8 horas, como realiza cualquier tipo de trabajador.
Bien, gracias, doctora. Fue una pregunta elaborada por el doctor Álvaro Arribillaga de Guatemala. Gracias, doctora.
Gracias, Álvaro.
¿Alguien más que quisiera hacer alguna pregunta, por favor? Pues bien, agradecemos, doctora Malena, muchas gracias por su participación, por compartir su experiencia y estos proyectos tan interesantes y sobre todo con un potencial impacto y contribución también para los programas de rotación de turnos, las actividades de prevención que podamos realizar dentro de las compañías, empresas o instituciones donde estemos trabajando tanto en Latinoamérica como alrededor del mundo. Nuevamente, felicitaciones a ambas, la doctora Kiriaki, doctora Malena. Thank you very much to both of you. And we would like to invite Dr. Imelda Wong as the chair of the Scientific Committee of Shiftwork and Working Time for the closing marks of this webinar and for closing the webinar. I will unmute Dr. Imelda. Yeah.
Thank you so much, Dr. Chu. Can I just can I share my screen just very briefly? Do I have that
You have
option?
the
Yes, I
option.
do. Okay,
Yeah,
thank
you
you.
already have the
Thank you
option.
so much. Excellent. Thank you. So once again, I'd like to thank all of you for joining us today and bringing some very insightful questions and discussion points. I'd like to thank our speakers for presenting the latest evidence. It's always a learning experience for me. I'd also like to thank Dr. Chu for having this great idea for a bilingual webinar and for doing all the organizing and acting as the mediator or the moderator. I'd also want to end with a bit more information. As you can see on your screen here, Dr. Papanua has also mentioned this. We are hosting the 25th International Symposium on Shift Work and Working Time in Brazil from November 10th to 14th. This is a biennial event that's been held since 1969 and has been hosted by the Working Time Society and also the ICOH Scientific Committee on Shift Work and Working Time. And the theme of this year's symposium is Basic to Translational Science for Preventing and Managing Chronic Diseases in Shift Workers, with an emphasis on challenges and barriers hindering the process of progress. The symposium welcomes researchers, policymakers, industry and labor representatives, and health and safety professionals, and just generally anyone who's interested in the subject of shift work and working time. Our registration abstract submissions are still open, so I hope that you will all consider joining us in Brazil this year. I can't say enough about this conference. It's where I got my start and met some really incredible mentors and colleagues that I continue to work with. In addition to the fantastic range and presentation topics at the symposium, it's small enough that everyone can mix and mingle and network outside of the sessions. And for the Working Time Society and the ICOH Scientific Committee on Shift Work and Working Time, mentoring and collaboration are keystones of our organization. So for more information, please visit our website at shiftwork2025.com. And so again, everyone is welcome, and I hope that we can see you there. And I will turn things back to you, Dr. Chu. Thank you so much.
Thank you, Dr. Imelda, Dr. Kiriak, and Dr. Malena. And of course, thanks to all the attendees. It was an honor to share this morning or afternoon or evening with all of you. And we would like to invite you to future events with the Scientific Committee of Shift Work and Working Time and other scientific committees that we are currently working on. Thank you so much, and well, have a good afternoon or evening. Thank you. I have put a Google form link so you can fulfill with your information, especially with your email, so we can share with you the recording.